Good morning. Are you awake, Louie?
Yeah.
You sure?
Yeah. I just woke up.
You're running class today, so I hope you're ready.
Okay.
Get that email?
Yeah.
Yeah. Oh my God, you just went with it. I love it. I saw your TikTok.
Oh, you did?
Well, actually, my whole clinical group did.
Oh.
I know a lot about you. I'm recording this right now. Yeah, it was adorable. Oh my God, I love it. You guys are so fun. I want to do one with our clinical group, but we haven't really had a lot of time. But it's fun, right?
Yeah.
Or were you forced? Because I think we were the only guy.
Oh. You mean yeah, I'm the only guy, right?
Were you forced into doing it, or you wanted to do it?
They said they're gonna do it, so I just joined in.
Oh, I love it. Good. Well, I enjoyed it. I thought it was really good. You got some moves, man. Now we got to get baby Alex. We got to get him going. Got to get him dancing. All right. Happy Monday morning. Does it feel more like a Monday than normal, or is that me? I think I said that last time. It feels like a Monday, right?
Yeah.
Like, is everyone exhausted? There's Katrina. I didn't see you first, okay? I'm a little bit disappointed.
Sorry.
You're all.
I had to feed my dog.
Yeah, well, and that's why I was 2 minutes late, because we had a disagreement, Tyler and I. So I won eventually. So let me see. You said your dog got a haircut?
Oh yeah. Okay, hold on.
I know you're struggling with this, so emotionally. Hi, Rosemary. I haven't seen you in a long time.
Okay.
Good morning.
You can't really tell, but like the front of his head is like really choppy. Like if you like turn the back, first of all, he had really long hair, and then I like forgot to put the like guide on the clippers, so I had to shave him to the skin, and now he's sad.
Well, I still think that he is very handsome, and he had a very cute costume, and yeah, he's okay. He forgives you. See, go boo. It's a boy, right?
Yeah, it's a boy.
My boy is trying to steal my food. I can't eat during this class, okay? Relax. Okay. All right, so we waited our 5 minutes to start class. So, as obviously you've noticed, I didn't post a video that I was gonna post, because I was gonna post it, and I don't post unless I feel I have the energy and my brain is somewhat working, because I usually make 1 or 2 like verbal errors because I just am not thinking. So, and I did make 2 other videos. So if you saw, I posted a poster video, which, by the way, there is 2 mistakes. One I already wrote on there, and the other one has to do with renin. I made sure to like change it. What did I say? I said renin produced an decrease in blood pressure, and as we all know, renin does the opposite. So thank you. I think it was Tam or Ken. I can't remember. Now you guys are like one person to me. So I forget. One of you said something, so thank you. I appreciate that. And my apology. So if you did watch it, and if you didn't, you get to watch it, part of it today, because I actually really think it really helps. I have a goal. So my goal today is this. The last time we met was, I think, good in a simplistic way. Hopefully you did. Hopefully everybody read. Now we're going to take it a step further. So I have 3 NCLEX questions. I made questions just to kind of throw out there and ask to keep your brains going. And one of the main things with endocrine, and I think I'm sure everybody kind of has established this. Endocrine, and I've said this before, this is probably one of the largest med surge things to teach, if you will, or to learn. And most students tend to not like it because it's not because it's hard, it's just so much. So I'm trying to, again, as I always say, I don't think every single thing is important. Like, is a patient ever going to ask you, in my opinion, like the difference between negative and positive feedback? And if I teach you that today, are you going to remember that in 2 years? I want you to remember like the important stuff. Like, why is the thyroid important? Why do we have a thymus? You know, things like that. So I just wanted to, again, kind of remind you of that. Housekeeping, there's like one thing. The quiz did open today. Today's the 2nd. Yeah, so the quiz did open today. Has anyone taken it?
No, I was going to wait till after this class.
I was going to say we could take it together. You guys want? I don't know. Well, if we have time, if you don't have to, you can sign off. I figured at the end, if we have like a little bit of time, maybe just for fun, because I think that everybody, let me just put it this way. I've gotten a lot of text messages. People are having a really hard time right now. And I really understand that. And myself too, physically, like those of you who know me in clinical, I actually did crack my rib when I fell in the garbage.
Oh, crap.
Yeah, long story. And I have an ulcer right there. So I was actually in the hospital last night, which is why I asked Katrina to teach the class last minute, because I was like, I don't know if I'm going to be able to do it, and I didn't want to miss 2 weeks in a row. So I'm going to do my very best. As you can tell, I look like I feel. And I drove back from Tahoe, so I didn't get back till about 1 in the morning. So I'm going to do my very, very best. I have a full outline. I'm ready. I was up at 4. So we're going to do this. Okay. So housekeeping, I wanted to let you know, that's why I seem a little bit not me, like, and could potentially throw up at any minute. Who knows? Could be fun. And the quiz does open today. So at the end, I mean, if you guys want, they're not hard. I know that. So, but if you want, I thought it'd be kind of fun to take it together. And the other students will still get a chance to see it, but they have to watch the video. So you'll have to make me a promise. I know all your besties may not be here, but you guys are here. I know some of them have clinical. So if they have clinical, you can tell them. But if they don't have clinical, I want to see if they watch the darn videos, because I know a lot of people don't. And I spent a lot of time on these. So I don't take it personal at all. So I, just like a lot of the questions that people are getting wrong, I know who's watching the videos and who's not. And I know we're all busy. I totally get that. So if one slips by, but if I say one's really important, like the poster video, in my opinion, I thought was really good. It really broke it down. Right, Mel? Do you agree? Like, maybe it was just me. Because even for myself, I'm like, oh yeah, that's how it works. And it was like really like clicked everything. Okay. So yeah, goal today is to find out, excuse me. Sorry, I'm watching my phone too, just in case anyone can't sign in. I put the thing in 2 places to make sure everyone could get in. Everyone's in. Okay. So I think that you probably are all noticing that the endocrine system, not only it being large, it also is basically, if you know what it does, I know the book said this, but I'm just going to say it because I said this, I think, day 1, and I've always said this. If you have an idea of what a gland does and kind of the hormone, again, it doesn't have to be spot on, but what hormone it produces, you're going to have a much better investigation technique of what could potentially, when something is going wrong, it's going to make so much more sense. I actually wrote that down because I knew I was going to not say that very articulately. So if you find out the cause, many times, this is how we do this in the endocrine system. If you can figure out the cause, like, okay, I'm feeling super, super tired. I think I said this last time. I love the thyroid gland. It just makes so much sense to me. I'm feeling tired all of a sudden. this is happening. And a lot of times things get missed because people, oh, I'm in menopause, or oh, I'm in nursing school, or all of this stuff, right? This is why this is happening and this is happening. But that's how we can go down the road. So if we know what it does when it's not doing what it's supposed to do, that's going to help you figure out how to kind of guide the physician or NP or whatever down that road, right? But you don't need to know every single, you could just suggest, hey, I suggest we run a da-da-da-da-da. Because didn't we mention last time, most of the time, so this is one of the questions that I have, and I'm going to just kind of spit them out here and there. I think I have 17. What are the main ways we usually figure out if there's something going on in the endocrine system, other than, of course, history and physical assessment?
We do blood work.
Well, absolutely. Blood work is actually, I would say 50%. I mean, well, maybe even, blood work, we do it all the time. So blood work is definitely, I kind of think number one. I know we do scans too, but I think blood work is number one. Definitely, Lizette. What else?
I think we also can run analysis on like specific hormones. So like we take like say on like blood work again.
Exactly. And then we can kind of hone in. So we may start big because we may not know. I mean, like so many things look so similar, we may not know. So we may do something large and then say, and then we hone in. And think about so what is the control center? Not the master gland. What is the control center of the endocrine system?
The pituitary?
Say the other one that's above it.
Hypothalamus.
Yes. So, and again, everyone calls things a little bit different. To me, that's the control center. The pituitary gland is the master gland. So the pituitary gland is the one doing kind of like all the work as far as like getting things to where they need to go. But the hypothalamus, which we'll see in part, I'm not going to show the whole video because today we're basically, oh, I'm sorry, you guys, forgot to tell you. So what we're doing today is what we would have done last Monday. And then I promise, I actually booked in time tomorrow. Is Celine on here to make me remember? She's always here. Okay, Katrina, you got to do it. Okay, so Katrina's job tomorrow is to make sure, because I'm sorry, because I'm looking and that's the only person I see. Oh wait, Ken's here too. Okay, so your guys' job tomorrow is to make sure Miss Amanda gets out of clinical on time so that I have to tutor someone for their NCLEX because, I have so much time. And then after that, I plan on making the video for the second half of this chapter. So you're basically kind of getting everything on time, just one day late, if that makes sense, because you would have got the second half today. And that's how I justified it in my head. I was just like, I literally can't do this today. I was so sick yesterday. So, sound good? And you won't watch it anyway. So, are you gonna watch it?
Yeah.
Yeah. Who is it? Daniel, are you gonna watch it?
Of course.
Daniel, why aren't you?
Oh, yeah.
Oh man, I was yelling at the other one. But good job.
Mm-hmm.
Thank you.
Thank you. Okay, good. Perfect. All right. Okay, so let's begin. I don't know why it takes me so long to start and like end. We all have our stuff, right? Okay, so today it's only 10 pages actually in the book. So really it has mainly to do with the pituitary gland, which actually is my favorite. I think that's my favorite hormone, just if anyone cares. That's not on the test, but I think that's probably my favorite hormone because it's bossy. And I'm bossy, so I kind of like the whole, and I like the whole beauty of how it works and how the anterior and the posterior, there's just the whole thing. So can someone tell me this is just a quick review, and I'm going to just do this throughout. What is what does the pituitary gland hang from?
The hypothalamus.
Hypothalamus.
Very good. And they are, if you watch my video, you already know this, they're best friends, right? They are a fighting force working together to make sure that your body does, and what is my favorite word? It starts with an H.
Homeostasis.
Homeostasis.
Yes. And that's exactly what it's really there for. That's why, I mean, most of what your body does is there. Is your endocrine system attached to your nervous system?
Mhm.
It is.
Mm-hmm.
And by what gland? Gland Z.
Like the adrenal gland, the mammary gland.
What are the two main glands that are, okay, so there's 3 glands in your brain. What are the 3 glands in the brain?
Hypothalamus, anterior pituitary, and the posterior pituitary.
Correct. And what's that one that I say funny?
Pituitary?
Everyone forgets the pineal gland. What about the pineal gland? Everyone, it's like, even in the book, I'm like, where is it? They don't even talk about it. It's like I don't even know if it's mentioned. But just a reminder, what does the pineal gland secrete?
Melatonin.
Melatonin. And that helps with what?
Sleep.
Yes, and your circadian rhythm. Very important. And because I'm me and have 0 life, on my way home from Tahoe last night, I was just listening to like random podcasts on endocrine system. And I learned that it's not actually 100% defined in the articles yet and like in all the studies, but there's been some research showing that as you age, your melatonin levels actually go down. And that's why sometimes, not all the time, of course, right? And not everything's black and white, but that's why sometimes that the elderly, I don't like that word either, those that are older have trouble sleeping. I didn't even connect the two. I knew that is why, but I, thought of, okay, nocturia and, just maybe you have a lot on your mind, or you don't do enough, as much during the day when you did when you were working, right? So it might be harder to go to sleep. Well, your melatonin levels actually change your circadian rhythm. So that's kind of interesting. So I just wanted to give our pineal gland a little shout out, but that's the basic of it. So there, we talked about it. And I like that gland because I prescribe, if you will, a lot of, why can't I see myself? Oh God, because I don't want to. Okay, never mind, I'm moving. So we do a lot of melatonin. Is melatonin considered habit forming?
No.
Correct, because it does not ignite dopamine in what part of the body?
The hypothalamus?
Oh, sorry, forgot. Never mind. Wrong school. Never mind. You guys are off the hook. Okay. So what I want us to do real quick is we did our housekeeping. Now we have the very beginning of the chapter. It talks about, and we talked, I believe, about this the first day. So I'm not using the PowerPoint, by the way, today. I might use it in my video, but it's everything I already wrote down. So I'm like, why? You can just listen to me talk because it doesn't make any, it's the same thing. So we've talked about what diabetes insipidus is, right?
Mhm.
Okay. So diabetes insipidus has to do with what hormone?
Antidiuretic hormone.
Exactly. And what does an antidiuretic hormone mean? Like so it's anti-diuretic hormone. So what is it going to do to your body?
It helps
Keep you from
the
peeing.
kidneys retain water.
Perfect. And I heard several people, so good job. So perfect. So it's going to help us retain water. And the reason I'm kind of repeating that is because then we learned about something, if you guys read the chapter, something else was mentioned. So what's the opposite of diabetes insipidus? I'm not saying it. I'll stay here. I'll tell you what page it's on.
Polyuria?
That's a symptom. It's on page 279, or what? I can't even read. 791 at the bottom on the right.
It's a syndrome. It's a specific like syndrome that's like the opposite. So you have excess amount of fluid.
Exactly. So what I like about it is that it's the opposite. What I don't like about it is that I can never remember what SIADH. I mean, ADH. Obviously, I know what that stands for, but it's a syndrome of inappropriate. It's just such an odd name to remember. So I just go by the acronym, which is SIADH, which results from too little or too much ADH.
Too much ADH.
Exactly. So you're going to have too much, and if you have too much ADH, you're going to have fluid overload. If you have too little, you're going to have fluid deficit. So basically, it's two different syndromes, if you will, just the opposite. And I don't think I've ever seen, did I in nursing school? I've met patients that have had diabetes insipidus, but I don't think I've ever met anyone that has anyone ever met anyone that has had the other one, the opposite?
Mm-mm.
It doesn't seem super common. No? Okay. All right. So we will do more talking about that. And today, my focus is asking questions and videos. And one of the videos is mine. That's why I'm using it, because I don't want to just show videos and like not teach, because that doesn't seem like what we should be doing. All right. So let's ask all the questions and get this out of the way. And then, like I said, at the end, if you guys want to take the quiz together, we can. If not, then you don't have to. Okay. So I already asked you that. Good job. I think Kalisha answered that question. What is the control center? I'm just going to ask again because we got it wrong.
That's a hypothalamus.
Hypothalamus. It does a lot. Isn't that so interesting on the poster if you watched it, how it connects, and it's just beautiful. What is a master gland?
Pituitary.
Very good. You know what I'm doing, right? The Amanda method of repetition. And then once we're done with this, then we're going to move forward. Okay. What are the parts of the pituitary gland? I know we kind of answered that. So we have, the stalk that comes down, and then we have our anterior, and then we have our posterior and anterior. One thing that how I remember, so which gland produces more hormones, anterior or posterior?
Anterior.
Yeah.
Exactly. And what hormones does your posterior secrete?
Oxytocin.
Oxytocin, correct. And what else? We just talked about it
The
whole time.
ADH.
The antidiuretic.
Yes, I heard you, Dan. Oh, you like yelled it. He's like, I got
ADH.
Yes, ADH, exactly. So that would be important. Why would that be important if I was a patient that came in and I was having some sort of issues going on? I mean, we don't want to always just get things that I've seen nurses do and physicians and whatnot is we get kind of this idea in our head, like it's got to be this, but we don't explore other avenues. If I had somebody come in and something was going on with their, who knows, could it be a kidney infection? Could it be, because when you have a UTI, urinary tract infection, doesn't that make it where you have urinary retention? Yes. And you might have burning, and you might basically say, oh, I know exactly what's going on. They could just and we're all nurses here. They could just be having a yeast infection, and maybe that's why the burning's happening. And maybe they actually have something going on with their pituitary gland, and you missed that because you didn't run the test and you just treated what was in front of your face. So as a nurse, that is something that is super, super important. Is not, we're human. We're going to miss things, and maybe a patient will have to come back. That's just life. But I really want to get that message across of always looking at the bigger picture, never just assuming because something's happening, oh, burning, oh, this is like such a standard UTI, because it could be something much, much more serious. It could be a tumor. And the tumor on the pituitary gland, we have a short video of a guy that had one. He literally had no hormones in his body because that's your master gland, right? And if your master gland is not working right, I mean, I'm sure he had some, because I don't think you can live without like zero. I don't know everything, but I'm pretty sure. But he had like hardly any, and his symptoms, I mean, he just felt terrible. And that it could have been missed. And if we miss it, and they're usually slow growing tumors, so you could have this person come in and then you treat them for something that they don't have, and then all of a sudden the tumor grows, and then now they're potentially obviously much worse off than they were, and then that we don't want that to happen. We're there because we want to solve the problem, we want to make our patients feel better, and we want to prevent further complications, right? So just side note. Okay, so we know that the pituitary gland, we have our posterior, which secretes AD, oh my God. Someone help me. Thank you.
ADH.
And oxytocin. One thing I forgot to mention, which I think you guys already know, another thing that oxytocin does, and I mentioned it in my video, it helps with human connection, which makes sense, right? Because when we think of babies and like uterine contraction, so that's how I remember it. So it's one of the several things. We have several different hormones and neurotransmitters, dopamine, all those things that help us, our pheromones, all of that. So it helps with human bonding and connection. If you didn't know that, I think that's a kind of a fun fact. Okay, so some of these questions, by the way, why I'm asking you is because they're on your quiz. So it's not just it is for fun because I love asking questions and talking about it, but some of these are on your quiz. And some of the questions, like the one I'm going to ask you right now, so I basically just told you this is going to be on your quiz, is because I want you to kind of think about it, and you guys are so smart, you're going to get it right away. But, okay, so first and foremost, what is nocturia?
Peeing at night.
Nation.
Straight up, Felicia. Pee, which is true. Yes. So it's when knock, right? Turia, and then urine. So, and the question in the quiz has to do, I made the patient older. You don't have to be older. I don't know about you, but when I wake up and I go to the bathroom, I forgot who I had a conversation. I don't want to put her on blast because she's shy, but hopefully her bruises are doing better now. I run into everything. I'm a mess. I'm half asleep. Sorry, excuse me. Most of you know when I do that. Give me just 1 second. It's okay, Jacob. My dog's
I know. I was gonna say, he's like, "Are you okay, Mama?"
because he knows Mommy's okay. I'm not gonna throw up. We're okay. Sorry, guys. I think most of you know I have hyperemesis. I'm not pregnant. And it's been acting up a lot lately. I think even worse since I fell in the garbage. Long story. Clinical group knows, you can ask them. Not my best moment. So okay, so I used specifically someone that was older to kind of, I didn't want to confuse you. And, if I said 32-year-old, something, and then I didn't want it to go to, oh, there must be something wrong with the brain. So, I mean, you can have a 20-year-old, a 15-year-old, a 30-year-old, whatever age. When you usually wake up to go to the bathroom, are you totally like, in the most part, cognizant and like awake?
No, totally out of it.
No, totally out of it. Either on medications or not on medications. So as nursing considerations, when somebody is suffering from nocturia, which it can be a symptom of several things that's kind of obviously our theme, if you've noticed, ADH and volume and urine and all that kind of stuff today. What can be, and Kalisha, I'm not going to let you answer this one. Not because I'm discriminating against you, because you just answered the last question. But let's think about that as a nursing perspective. So I have a patient. What could be potentially a hazard, if you will, if they're getting up to go to the bathroom? There's a couple things, not just potentially harm to their body, but what else?
The fall, risk of fall, because it's
Definitely risk of fall, risk of running into things, hitting your head. And then if you have nocturia and you have like, there's obviously different stages to nocturia. There can just be nocturia, you're getting up and you know how much you're actually urinating, but what can that potentially do to your blood volume?
Oh, they can have like dehydration.
Exactly. And do we think that's going to make their level of cognition when they wake up better or worse?
Worse.
worse.
Exactly. So these are like the bigger picture, like, okay, I have a patient with nocturia. They do live with someone that, you know, fingers crossed. And that would be a great point to do patient teaching, right? Teaching the spouse, like, you know, this is what's going on. And this is why I had you do the video to kind of learn. I cannot wait to watch them. I know you guys hate me for that. Sorry, but and I will be the only, I promise I will not show anyone else. Except my dogs. We will enjoy them together on a Friday night. That's when I plan to grade them. So these are things we want to think about. It's not just, okay, this says that, let's give them med, bye, have a good day. It's, can you talk to the patient? Can you talk to the family? Can you hold a conversation? Do you know what to ask if you kind of go blank and don't know what to ask? I mean, you know, sometimes when I'm lecturing, I'm like, and I literally just like blank out. How can I recover from that? So, you know, just kind of keep that flowing in your brain. So good patient teaching and making that connection and rapport with the patient. I know I'm a psych nurse, but psych nurse, not regular nurse, nurse, whatever kind of nurse it is, making that connection is going to make the treatment that much better. Okay, so we're not talking about the thyroid today, but I'm going to kind of slide it in here and there just to kind of get us thinking about it, because I cannot wait to I'm actually really excited to do the lecture on that and send it out, and hopefully you'll watch it. I'm not going to make it super long. I'm trying to cut down the videos because I feel like there's more chance you'll watch them. That's my hope of keeping them like 45 minutes and under, if I can get everything out. When does a goiter usually happen? Is it hypo or hyper?
Hyper.
Is it hyper or hypo?
Hyper.
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 Okay.
I'm looking at my poster because I'm like, I think I wrote it the other way around. Does this look familiar to anyone, by the way? Just asking.
Yes.
Okay.
Yes, it does.
Okay. Even if you gotta lie, thank you. I appreciate that. Yeah, my knees are still bruised from sitting and writing all that out. Okay, so we talked about what the pineal gland does. There's something brown on my finger. That's usually not good. All right, finishing up these questions here. How many glands do we have in the brain? We already talked about that. We have 3 that are in the brain. And then that's the cool thing about the endocrine system, because everything is kind of spread out. Whether this is necessarily important or not, if this helps make a connection, because like I said I don't remember if it was you guys or at San Jose State, but I had mentioned I think it was them, but usually if you have information about something, okay, and you get a question or you are trying to figure something out or you're doing homework, a lot of the time you can take your base knowledge. I do this at work all the time and teaching all the time. I can take my base knowledge, think about it, and actually make that connection. So sometimes when I'm talking and you're like, why does that matter? hopefully someday you'll see why I'm saying it. So for example, I'm going to say it right now. So our pituitary gland, and I mentioned this in the video as well. And at first I thought, who cares? But I now it makes sense to me why I think I do care. And again, not because it's going to necessarily, you're not going to explain this probably to the patient unless they're having symptoms of something going on with it. But when your pituitary is hanging down from your hypothalamus, you know how we have our posterior and we have our anterior. What is our posterior connected to? Is it connected by blood or nerves?
Blood.
Nerves.
Nerves, exactly. And then our anterior is connected to in the bloodstream or with nerves?
Also nerve.
It's actually blood.
Is it?
It is. And the reason I'm telling you this too is because it helps me remember, because most of what we do in the endocrine system is blood. So the nervous system, which I mentioned in the video, it goes very, very fast. Things get there quickly and it's done. Neurochemicals, neurotransmitters, my favorite thing in the whole world. And then in our blood, that's usually why, and we have glands all throughout our body. That's usually why it may take a little bit longer for things to happen. And usually it may not just last for like an hour. It may last a day because it's in the blood system. So it's going to take longer to kind of filter out, if you will. So usually that's how I remember that the anterior pituitary gland, it does a lot more because do we have a lot of blood in our body? Yes. Hopefully we have a lot of blood in our body. I'm opening the chat now. Sorry, guys. And I thought goiter. Yeah, thank you, Jessica. Yes, you're absolutely right. So a goiter can be from, and I actually have that written down, and then I forgot to go back to it. So I literally wrote it right there. So yes, a goiter can be from hypo or hyper. So that's another kind of aspect of, if you have a patient come in and they have a goiter, we can't just automatically assume, oh, you have hypothyroidism, because that might not be what it is. So what are you going to run? You're going to run a blood test, right? And you're going to probably run T3, T4. But what else are you going to run? It's not just that, right? Don't I want to know something about maybe the pituitary gland? Because doesn't that have something to do with it?
You want to test to see what their TSH levels are?
Yeah, definitely. Exactly. Because exactly, because they connect. So and many times what I've seen happen, and this actually happens in psych a lot. Whoever's on here and works in psych would probably agree with me if they've seen lab work, is that it can potentially be missed. And then they have to go back, redraw more blood, and then test for what your pituitary gland is basically telling your thyroid what to produce and how much to put out. Very good. So, and hopefully that will make sense when I show a little bit of the video, if you haven't seen it, how all of those connections are made. Very good. Okay. Can somebody explain to me, and this was in the chapter as well, I believe, yeah, the first 10 pages. So we have a primary, and then we have more of a secondary way of how our body communicates through hormones. What would be an example of, and Lizette kind of just said it, so that would be a secondary, right? So Lizette, can you say what you just said again, how the pituitary gland communicates with your thyroid gland?
It helps release TSH, which stimulates the thyroid gland to release thyroid hormone.
Beautiful. Beautiful. Simply put, do you see how there's no, I mean, that it's just, there it is. It doesn't have to be more than that. If you want it to be, it can, but it doesn't. It's just perfectly put. That's excellent. Is that now, not anyone can answer, is that a primary or a secondary?
That would be a
Secondary.
That would be secondary, right? Because you have one thing telling something else what to do. And that's a lot of actually how our endocrine system works, but not always. There's some glands that will secrete their own hormones and then, you know, whatnot. So can somebody give me an example? And it can even be the thyroid as well. I'll let you guys take a grab at it, but you can use the thyroid as an example. That's just to kind of keep it together. But what would be primary?
The thyroid gland is diseased, and thus it would cause hypothyroidism.
Exactly. So it can be two different reasons happening for from two different sites. So I'm going to test both things, right? Because I want to know what's not. Now I know what all of these things do, which is what the chapter previously was, and kind of why we're reviewing it just a little bit now. And then now I know what to test, and it makes more sense. And more than likely, you're going to remember that. So you may not remember every single thing because it's not as I almost said popular. Well, no, it's not. It's not as popular. You don't see it as much. But thyroid, you're going to see a lot. What else? I have my posters here. But there's a lot more, like some growth hormone. And as a side note, you guys know that growth hormone isn't just like, when we see, I have trouble saying it, those tall people. Say it for me, acromegaly. Big hands, big features. That's not just like the only thing that the growth hormone does. So your growth hormone, there are other reasons and purposes for that, and we're going to talk about that more towards the end. And I will make sure you get a break too. Don't worry. Okay. All right. So we got that. Good job, Lizette. That was really good. Okay. So we already talked about ADH. What does ADH do? What is the other name for it that starts with a V as in Victor? ADH.
Vasopressin or something like that.
Yeah. Actually, that's a prettier word, vasopressin. It's vasopressin. It's the same thing.
Okay.
No, you're right. I cannot tell you. I'm the last person to tell someone how to pronounce something. I might call it that from now on, actually. Okay. This may or may not be on the quiz. Just putting it out there. Does DI have anything to do with does diabetes and mellitus have anything to do with diabetes insipidus?
No.
No.
Good. I know it seems simple, but just sometimes when we read questions quickly, we just answer. So you have plenty of time to take your quiz. So I hate seeing when people, I'm like, I know they know that answer, and then they missed a point, and it sucks for me too. We talked about so we're going to come back around to it. Somebody else, I think it was Lizette that explained it. So can somebody else tell me what is the difference between SI versus SIADH? Or sorry, DI. So diabetes insipidus, you have what? Too much or too little?
DI is too little ADH, and SIADH is too much
Perfect.
ADH.
So probably dehydrated, and then the other one, too much volume. Very good. Perfect. Thank you. I'm not going to ask you that again, although I do have a video on it. Okay, so last question that I have for you guys is another nursing consideration, because that's important, because actually I have 3 more, but because that's important. So if you have a patient that comes in and they do have SIADH, what are some, either or actually, diabetes insipidus or SIADH, what are some nursing considerations that, let's say they're actually in the hospital, so they're there. What are nursing considerations that you're going to want to look at? Because we're thinking about volume in the body, right? Whether
Like their INOs and their weight?
INOs, weight. I'm going to check them off as we go. Good job.
Their urine gravity.
Perfect. Ooh, that's a good one. I don't even have that one down. Yep, gravity.
Vital sign.
Vitals.
Edema that you can find it on the face or
Absolutely. Very good.
Watch for hypovolemic. SDI.
Who is that? It's Jessica. You're in the snow.
I'm at the White Sands actually.
Oh, it's sand? Oh, it's pretty. I want to be there. And what did you say, Jessica? What was your answer?
I was looking for are you talking about the SDI, right?
Either or. Kind of just natural considerations, vital signs, I's and O's, things like that.
Watch out for water toxicity and hypovolemic shock.
Perfect. Excellent. I'm gonna call that. I have 2 left.
Skin trigger.
Perfect. Actually, I have 3 left, so now I have 2 left.
Level of consciousness.
Damn, that's a good one. Yes. Electrolytes. I have that one on there, and I'm gonna add the.
Hydration.
Say that again.
Dehydration.
I'm gonna put that under. Yes, we'll just add that under here. Dehydration.
Level of consciousness.
Yep.
Weakness.
Now I want you to think. Let's think critically. We have a patient that could potentially have. I'm going to actually give you a specific scenario. We have a patient that's there because they have too much fluid volume. What is something very important that I'm going to want to monitor?
Hypertension.
Exactly. Hypertension.
Edema.
Exactly.
Long sounds.
Boom. That's exactly. Yep. See, you guys got them all. Perfect. Good job. And that's just to make it a little more applicable to look at the big picture. And I know you know all of this stuff, but it's bringing it back to the forefront of your brain. Excuse me. Okay. Perfect. Good job. So is anyone in clinical right now at this time of the day? Do you guys know?
I think Giovanna is in a clinical right now.
Okay, so there are people. Okay, all right. I was gonna be mean and say let's take that and like let's take the quiz. I'm not gonna record it. But if people are in clinical, I would never do that to them.
Yeah, I believe Emily is too.
Okay.
Right now.
Oh, that's right. They have Monday morning. Okay, then we won't do that. We won't be mean. Because you all woke up early on a Monday morning to be here. I really appreciate that. Thank you so much. It shows. Can I just say something really quick so that you, and this has something to do with being, as far as even an employee, and I know most of you probably know this, you all have jobs, you're good, I work with you, you're good students. If we make this attempt, like for example, let's say, I'm just going to call you out because your name is there. So, and I know it makes you uncomfortable. So Daniel Ohm, he's here. Like most of you, it's a very consistent group, and Kalisha will be here if she's not in clinical, and all of you, right? I'm not going to name all of you that are here, but there's a lot of consistency, and I think that's really important, because what that does is it shows that you are putting forth that effort. So it gives me even more confidence, and other instructors or potential employees, where if something were to go wrong, and let's say, somebody's child got ill and I got a text and said, oh my God, Miss Amanda, I'm so sorry. I know I waited till the last minute to do my homework. I'm really stressed, but you're here. You're a good you see what I'm saying? You're kind of building up your chips, if you will, of showing that you care and you want to be a good nurse, and you're doing everything you can to do that. I'm not saying that people that don't come and watch the video later are not doing that, but the fact that you're getting up on a Monday morning when you don't have another class till like 11 or something, I just want to give you a pat on the back and say thank you. And that works well at work as well. If you don't call in sick just for no reason, and you only call in sick for the real reasons, you're usually not going to feel that pressure from your boss, unless you have my boss. Right, Pedro? He's so mean. Right? Pedro, I know you're there. He's on his iPhone. He's probably at work. We'll leave him alone. Okay. Because he's here. Okay. So we're not going to do that. That's a dumb question. True or false? Can somebody that has a human growth disorder have mental delays?
I would
True.
say yes, true.
True. Yes. And that's usually as they're growing up. So just it doesn't have to be, but that is what the study showed. The book doesn't say that, but I'm just telling you. Pedro. I'm here, and yes, he's mean. He is mean. I was so sick last week. No feel better, no nothing. I'm COVID negative, da 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 da. Like, what? I'm there every time. Like, just mean. I'm so pleasant and nice and happy to be there. Don't you hate that? It can really ruin the morale. Okay. Oh, okay. Last question from this here. This is a good one. Another growth hormone question. So can any of you name some reasons why you might have a growth hormone issue, if you will? And I'll name the first one, tumor, of course.
Would it be trauma?
Yeah, I was thinking nursing, psych trauma, and I'm like, no, yeah, but yes, trauma. So like accidents, yeah, absolutely.
Malnutrition.
Yeah, good job. Yeah, I didn't think you guys would get that one. Malnutrition. And there's two other ones. I want you to think of what's in charge of your brain, or your endocrine glands.
Is it the pituitary? Hypothalamus?
No, you guys did it together. It was a team effort, and you were both correct. Your hypothalamus and your pituitary gland. Yes, that is absolutely correct. Something could be going on there. And then the last one I'm just going to say is genetics. Genetics plays a role in many things, but genetics can actually have something to do with the growth hormone deficiency. So, or the other way around. Perfect. Okay, so those were all my kind of like not super hard questions, but just some things to get your mind going. We're going to take a break soon, I promise. Okay, this will happen. I had a plan and I totally didn't even, I'm like going from the middle out. Okay, so we did housekeeping. We were going to watch Nurse Blake, but I was 2 minutes late, so we didn't have time. Let's do the 2 short YouTube videos, take a break. And then what we're going to do is come back. We're going to do 3 NCLEX questions. And then we're going to go over my poster. Because even if you've watched it, I watched it like 4 times. So even if you have watched it, I know you're all probably going to like go on, like, I can't see your face and like go away. I would really, really encourage you to actually stay and watch, because it really helps to understand, and that's just my advice. So Luis, I see an iron behind you. Do you iron?
Yeah.
Yes.
It's so cute. I love it. I do not. Okay, so we got this guy here. Let me pull him up. Oops. Nope. Sorry, Nurse Blake, not happening today. We don't have time for that. We're on a budget, or not a budget. What's it called? We're on a time
crunch.
Yes. We got things to do. Okay, so this is acromegaly, which I don't say right. Pituitary. Perfect. Oh, what is it called when you have your pineal gland removed? If you don't know, it's going to be on your NCLEX questions. Were you going to say something, Luis?
Is it pinealectomy?
You would think so, but no, because they're mean. It's called hypophycectomy.
Pituitary gland?
Am I wrong?
No, it's on page 795.
Yeah, and don't look at that page. Oh, you can look at that page. Don't look at the we're gonna do 3 of the questions of that. I wanted to do those NCLEX questions this time. Oh, don't read your book. Thank you for following along. I'm right though. It's a pituitary gland. I mean, pineal.
Pineal. Actually, no. It says pituitary gland is the hypophycectomy.
What? This whole time in my life? Oh my God. Sorry. Now I don't believe you. I have to look it up. I'm like, I want to see if the internet's wrong. My entire life I remembered this. I thought from nursing school and I was so like proud. And it's I was wrong. So let's use that as a learning tool. Like a lot of times medications, you know, they sound super similar, right?
It says here it's pinealectomy.
Right? Why is it saying different things? Because now I just looked it up online and said pituitary, but right here it says I asked the wrong word. I'm sorry. It's hypophycectomy is surgical removal of the pituitary gland to treat cancerous. The word I'm asking is hypo. Wait, it's the same word. What? Okay, I'll do that at break. Let's not worry about that right now. That doesn't make any sense. Like I'm not making much of right now, but I couldn't not come to class this morning because I was not here last week. All right. Let's open up this guy. All right, so I'm going to share my screen. Let me know if you can see it. Election day is tomorrow, by the way, just reminding you, because it just popped up on my screen. Oh, private stuff. Okay, can you guys see that?
Yes.
Okay.
First thing to understand is the normal anatomy in this area. You have to remember the pituitary gland measures about the size of a kidney bean. It sits right at the base of the brain, right above the earlobes, and right in the middle of the head. And it controls all the hormones in our body. And that's why we call this the master gland. And as lesions, whether it be a tumor or a cyst, grow within the pituitary gland, I kind of break it down to 3 problems it can cause. The tumor itself, because it arose out of the pituitary gland, can actually make one of the hormones the gland makes. And these are called secreting tumors. They can cause syndromes like hyperprolactinemia, elevated prolactin levels. They can cause Cushing's disease or acromegaly. However, later in life, the majority of these tumors do not make any hormones. So then as the tumor grows, the second thing that happens is the gland gets compressed. 2 things can't live in the same space. And so whereas the average tumor size may be the size of a walnut or a golf ball, you can imagine taking a golf ball and squeezing it into a kidney bean. What happens over time is the gland gets compressed. And as you slowly squeeze the gland, the hormones the gland makes slowly shut down. Typically, the first hormone that's lost is growth hormone. Hence why in kids, short stature is one of the most common symptoms that develop. However, after puberty, we don't grow any taller. And so even though most adults will lose growth hormone, they'll be asymptomatic. The next hormone that shuts down are the sex hormones. So in women, it causes premature menopause. That's why oftentimes we'll catch these tumors when they're smaller. In men, the same thing happens, but they lose their testosterone. Unfortunately, as is most of the case, we kind of write this off and saying I'm getting older, or that's not oftentimes picked up. The third hormone that shuts down is thyroid, but you really need a large tumor and loss of a lot of gland before you lose that hormone. And the last hormone to shut down is cortisol, which is a steroid hormone. Now, thyroid and cortisol are both hormones of metabolism, and so it makes sense that the last 2 hormones your body is willing to give up. All these hormones have to be evaluated in all patients before we consider any treatment. And the last thing we worry about is if the tumor outgrows the cavity, which is called the sella turcica that it sits in, and so it starts pushing on other structures, the most important of which are the optic nerves. Right above the pituitary gland are the nerves that go from the eyes back to the brain, carrying all the visual information. And as these tumors grow, they can slowly stretch those nerves and cause progressive vision loss. Now, the body is pretty adaptive. Since these tumors grow slowly, there are some patients who will lose up to 50% of their vision and still not realize it. Eventually, once it starts affecting central vision, people start noticing vision loss, and that's when we oftentimes diagnose these tumors. But by that point, the tumors are already quite large.
Awesome. Okay. Thank you, Mayo Clinic. I just thought that was a nice short video of showing, like, okay, you have this tumor, which we talk about all the time. Okay, what's going on? What's going wrong? And how it can actually take, as I had mentioned earlier, how long it can take, and why things happen the way they do. I really like the part where he mentioned that your body knows. We talk about homeostasis, right? So your body knows how important metabolism is for your survival. So those are usually the last two to go. And most people don't notice it because they let it go. Like right now, if something was going on with mine, I would have no idea. I'd be like, oh, I just work like 100 hours a week and I'm tired and whatever. But there could really be something going on. I should maybe, go to the doctor, be seen, get tests done, make sure everything's okay. Because a lot of people have thyroid issues. I would say that's probably, like I said in the beginning, one of the most common things that I see in my patients. And I work in psych. So just putting that out there. Nice and concise. Okay. We're going to watch this. Then we're going to take a short break so that we can be done on time. Before we watch this, I'm going to ask one NCLEX question. And every single person on break, you have one job, because I'm getting mixed answers. They say sometimes it's called what I said and sometimes it's not. So please tell me that I have been not wrong my entire life about the removal of the pineal gland. Someone do that. Make my life not feel like I just have been wrong the whole time, because I've been teaching that at El Camino too. Don't say anything, Pedro. Okay. Number 1, and don't look in your book on page 813, okay? Please. So, which assessment finding in a patient who has just returned from having a thyroidectomy should be immediately reported to the healthcare provider? So, someone just had their thyroid removed. Which one of the following things would I immediately report to the healthcare provider? Neck discomfort, sore throat, tingling fingertips, and sleepiness.
Tingling
fingertips.
And that's because they usually at that point have hypo what?
Hypothyroidism.
Correct.
A muscle spasm, something.
Yeah.
It's a lack of calcium, something.
Yeah. Perfect. No, that's exactly right. So a lack of calcium. And why do you guys think there would be a lack of calcium? What else is around if we're taking
parathyroid? So that means something like you cause damage to the parathyroid.
Right. There's some trauma there, and that has a lot to do with your calcium. Exactly. Good connection. Good job. Neck discomfort. Probably I would imagine
normal finding.
Exactly. I would think that would be odd if there wasn't discomfort. But I wouldn't like freak out about it and call the doctor and say they're not in pain. Okay, good. Sore being throat. Oh my God, your throat being sore. That makes sense, correct? Because where's your thyroid? Katrina, don't laugh at me. She knows I can't talk. She's in my clinical group. I try, okay? The words just don't always come out. So your throat being sore is going to be very common. And then sleepiness. Why sleepiness?
You just woke up from surgery. You're always pretty groggy.
That would be one reason. Why could it be potentially for a few days another reason? Think about the calcium thing. You just took out the thyroid. So if you have hypothyroid, normally how do you feel? tired or like really up?
Really awake, anxiety, that type of thing.
No, I think
both.
because no metabolism though, so you've been feeling tired.
Exactly, because you're gonna have lower metabolism because it's hypo. I'm just removed it, and I haven't made, you know, the medication that we give. That's why we give the medication so that our patients feel whatever normal, hopefully, was their baseline. So the first few days, and what you just said, Kalisha, makes complete. Of course, that's not wrong. They just got done with surgery, but also if we think a little bit higher, it's going to be having to do with the fact that they just had the thyroid, which has to do with metabolism, removed, and they're not. It takes a while sometimes to get people on the correct dose, patients, of medication to help with like levothyroxine, Synthroid, things like that. Does anyone know what animal that comes from?
Is it pigs?
It's pigs, right? Because insulin's like cows or something. Yeah, I just think that's interesting. So like, what if someone's a vegetarian? What would you, I mean, patient teaching wise, just kind of like these things come up a lot, like a lot more than you'd think. So kind of thinking of ways how you would explain what would happen if the medication wasn't taken and this, that, the other. And it's very, very, very important. And that's another question that we'll read later, but don't go ahead, please. Okay. It is 9:08. Do you guys have 6 minutes left in you to finish up growth hormone? You got it in you? We can do this? Okay. Whoa, okay. Jesus.
Hi, this is Tom from zerotofinals.com. In this video, I'm going to be going through acromegaly. And you can find written notes on this topic at zerotofinals.com/acromegaly or in the endocrinology section of the Zero to Finals medicine book. So let's jump straight in. Acromegaly is the clinical manifestation of excessive growth hormone, or GH. Now, growth hormone is produced by the anterior pituitary gland. The most common cause of unregulated growth hormone is a pituitary adenoma, so a hormone-secreting tumor of that pituitary gland. And this adenoma might be microscopic, so small that you can't see it on a scan, or it can be significantly sized so that it causes compression of the local structures. Rarely, acromegaly can also be secondary to a cancer, like a lung or a pancreatic cancer, that secretes either ectopic growth hormone releasing hormone, or GHRH, or ectopic growth hormone itself. There's a structure called the optic chiasm, and this sits just above the pituitary gland. And what this optic chiasm is the point where the optic nerves coming from the eyes cross over to different sides of the head and enter into the occipital lobe, which interprets those visual signals. And a pituitary tumor that has significant size will start to press on this structure called the optic chiasm. And pressure on the optic chiasm will lead to a stereotypical bitemporal hemianopia, visual field defect. So what this is basically a loss of vision of both of the outer halves of the eyes, because as the visual signals from the optic nerve come through the optic chiasm, the signals that sense the outer part of the visual field cross over in the middle, and it's this middle part that is pressed on by the tumor, and this causes loss of vision of the outer sides of the eyes, which we call bitemporal hemianopia. So how does acromegaly present? If there's a space-occupying lesion or a significant sized tumor, you might find somebody with headaches or this bitemporal hemianopia. It can also present with overgrowth of tissues secondary to the growth hormone. So patients typically present with a prominent forehead and a brow that we call frontal bossing. They can have a large nose, a large tongue, which we call macroglossia. They can have large hands and large feet, a protruding jaw, which we call prognathism, and they can develop arthritis from the imbalanced growth of tissues around the joints. Now, growth hormone can also cause organ dysfunction because it causes growth of tissues outside of the muscles on the skeleton. So it can cause a hypertrophic heart, or very large heart that's not functioning properly. It can cause hypertension, type 2 diabetes, and it's also linked to colorectal cancer. How do you treat acromegaly? Well, you need to remove the source of that excessive growth hormone. So if you have a pituitary tumor, you can do an operation where you go transsphenoidally, or through the nose and the sphenoid bone at the front of the face, and surgically remove that pituitary tumor. And that's the definitive treatment for acromegaly in patients who have pituitary adenomas. Where acromegaly is caused by ectopic hormones from, say, a pancreatic or a lung cancer, then surgical removal of those cancers is also an effective treatment. If it's not possible to remove the cause of the excessive growth hormone, then there are medications that can be used to block the growth hormone. There's a medication called pegvisomant, and this is a growth hormone antagonist that's given subcutaneously and daily. More commonly, we use somatostatin analogs, which also block growth hormone. And remember that somatostatin is known as growth hormone inhibiting hormone. And an example of the somatostatin analogs is something called octreotide. And dopamine agonists also block growth hormone release. So this is things like bromocriptine that you might have heard of being used in Parkinson's disease. So just a bit of extra information. Somatostatin is normally secreted by the brain, gastrointestinal tract, and pancreas in response to complex triggers. And one of the functions of that somatostatin is to block growth hormone release from the pituitary gland. Dopamine also has an inhibitory effect on growth hormone release, but it's not as potent as somatostatin. So that's why we use somatostatin analogs and dopamine agonists to help us block growth hormone release when you have a patient with acromegaly. So thanks for watching. I hope you found this video helpful. If you did, don't forget there's plenty of other resources on the Zero to Finals website.
Okay, so there were 2 reasons why I showed this video. Well, I guess 3, obviously. Number 1, just for information. The second reason had to do with showing that you can have, what does ectopic mean? I wanted that to be, we haven't talked about that yet, and I think it's an important term to understand because we don't always have to have, as you saw in the video, a tumor happening in the place it's actually happening, but you can have it somewhere else and it's affecting that part of the brain or that part of the body. So what is, I know we know ectopic pregnancy, and so it actually applies to the same thing. So what does ectopic kind of in layman's term mean, if you, or in however you want to explain it?
Doesn't it just mean like in an abnormal place, like where it's not supposed to be?
Pretty much. Yeah, pretty much. Like they had mentioned the lung, which is, in my experience, the most common place that I have heard of it being when I, again, read articles and just am just curious about stuff. And since obviously we're doing endocrine, I've been reading some articles from the library, which are really hard to find and like pull up if anyone hasn't noticed that. Is it just me? It's like not very user friendly. So maybe I'll call one of you and you can help me, even though I took the class for flex hours and got paid for it. But anyway, so the ectopic, that's important to know because again, you're the investigator. Somebody comes in and they say this and this and this is happening, and it could potentially be something going on with growth hormone. Could that have something to do with pituitary gland? Yes. Can it have something to do with actually the hypothalamus? Yes. Because the hypothalamus, and again, you'll see in the video that I'm going to show after the break, that was the third reason I showed this video, is because this video connects really well with what my video shows, is that how things, one thing affects another thing, which affects another thing, which affects another thing. And I wanted you to understand that potentially something ectopic like this could be going on. We have a tumor in the lung, and that's what's actually affecting the growth hormone. And luckily we know so much now, not always, I mean, there's medical mysteries. We know so much now about that those two link, they're often linked together, that someone would probably hopefully order some sort of chest scan so that they'd be able to see that. They would do, like Lizette said earlier, they're going to draw blood. We're probably going to do a scan and do a history and do all of that. And that way we can get a diagnosis, therefore we can treat it. So it's 9:17. Let's go ahead and take a break till 9:30. If somebody can, it's number 6 in the book. It's the question. I mean, I know what the answer is because it just makes sense. But if they can figure out, am I really wrong this entire time? That's pituitary removal, or is that pineal? And what is a pineal removal called? So if you guys can come back with that answer, don't spend more than 2 minutes. Enjoy your break. That would be very helpful. And I'm going to do the same thing. So you're going to save my life, right? Yes.
Attempt to, yes.
Thank you.
It's in the book, page 795, it's mentioned hypophyseectomy is removal of pituitary gland.
Mm-hmm. That's what I saw.
I know, so did I, and I'm in denial. So I'm not.
I'm just confused. I don't know what to tell.
It just seems like it should have a better name. This whole time. Okay, you know what? I can process through this. I'm not going to ruminate. What does that mean? Rumination?
Reminiscing.
Reminiscing. Come on, my psych people. I taught you. What is rumination?
Stop thinking about stuff constantly.
I love it. Who just said that?
Me, Pedro. Hi.
Talk, so I don't know your voice. I'm like, that doesn't sound like Daniel's. One of the Daniels. Exactly what we do at night, all of us in bed. Like, why did I do that? And say, oh my God, I'm so this or that, or whatever. So I'm not going to ruminate about it.
What is it called again? Can you spell it out?
Rumination. Oh, yeah, Jessica. Yeah, we should probably talk about that. Rumination.
I always do that all the time.
I will type it out in the chat, so you guys can.
Pedro wrote it.
Of course he did. Did he give the explanation as well?
Is it Roman?
Thank you.
It's just rumination in your mind where you're constantly thinking about, like, oh my God, in sim today, I knew how to do that. Why didn't I do that? Or, oh my God, on the finger stick, or it's a very stressful thing where you're just ruminating and thinking about it, and it can be very distressful. Nursing students are notorious for this. It's kind of an anxiety. It's not a disorder, but it's anxiety. It's a lot of anxiety, and you're ruminating, and you can't get it out of your brain. So,
I didn't know that was like a part of anxiety.
But it's not a diagnosis. It's a symptom of anxiety, but you don't have to have anxiety to have. Does that make sense? You don't have to have anxiety disorder to have rumination, but it is a part of anxiety. Okay, you guys deserve a break. I'm gonna give you. Let's do 9:30. 10 minutes is enough, I think. Let's do that, and then actually that ends perfectly. I think we're gonna end right like a little bit early, unless you want to take your quiz and then you can stay, just as a thank you and good job, and I appreciate you being here. Okay, so I need to open this so I can put this on. I want to eat something, so I want to pause you so you can't see me. Okay, go enjoy. And I'll see you guys in 10 minutes.